Thank you, Dr. Holland, for this kind presentation. Dear colleagues, even if I cannot speak Italian, I'd like to speak Italian to you, to thank you for this invitation. I'm very happy to be again in Grosseto and to testify to the exceptional growth of this unique society. I was here in this conference for the first time over 10 years ago. And Italy has been and still is a center of innovation for ophthalmology, in particular in ophthalmic surgery. The best example of this excellence is exactly this unique research in the field of the Italian Society, stem cells and ocular surface. So I want to thank Professor Sarnicola and the organizers of the conference for this wonderful opportunity. And now, in order not to abuse of your patience in listening to me in Italian, I'm going to switch to English.
So when we first came to this lovely city in 2010, when we arrived in Grosseto, we were told that there was going to be a soccer game between the Italians and the Americans. At first, we were very excited. Ed was ready, I was ready, and it only occurred to us when we got on the football field that we were about to be massacred by the Italians. And indeed, we tried to escape, but there was no escaping, and we finished the game. Nonetheless, despite our humiliating defeat at the hands of the Italians, we remained good friends and have spent many wonderful times together over the years. We all love doing DSEC, DMEC, DALK, all the wonderful surgeries that we've heard about this morning. But there are certainly new medical therapies in corneal external disease, which I'd like to cover today because they're great tools for us, even as surgeons. King Solomon is credited with the writing of the book of Ecclesiastes, and he wrote, "Mashaya husheyeh u'mashanasa husheyaseh ve'ein chol chadash tachta shemesh." That which has been is that which shall be, and that which has been done is that which shall be done, and there is nothing new under the sun. I think King Solomon was not talking about ophthalmology, he was talking about human nature. Nonetheless, I'd like to show you some new devices and procedures that we have available that have their roots 100 years ago, and hence the name 1917, 2017, 2117. So new ideas developed from clinical needs have a basis in physiology, may come from other fields of medicine, may result from out-of-the-box thinking, and new ideas often stem from old concepts, and that's what I'd like to talk about today. We're going to say a few words about a sample of these, including scleral lenses, amniotic membrane, collagen cross-linking, new therapies for dry eye, drug delivery, and endothelial cell replacement, about which we will hear in great detail from my esteemed colleague, Dr. Kinoshita. Let's talk first about optical correction. Scleral contact lenses for the corneal surgeon have become a tool of major importance. And that's because scleral lenses can help us avoid doing surgery in many cases. Even though we like to do surgery as surgeons, this is maybe a better option for our patients. The indications for scleral lenses include ectatic diseases, irregular astigmatism, and intolerance of traditional contact lenses. In addition, however, therapeutic lenses, scleral lenses have therapeutic indications. And so they can be used for inflammatory conditions such as pemphigoid, limbal stem cell deficiency, severe dry eye and graft versus host disease, Sjogren's syndrome, Stevens-Johnson syndrome, peripheral persistent epithelial defects, and neurotrophic keratopathy. Why a scleral lens can be therapeutic is the configuration of this lens, which rests on the sclera and contains a layer of fluid between the lens and the cornea. And of course, there is an optical zone centrally. These lenses can be very complex in their construction. And as you know, there are many types of these lenses. Scleral lenses function because of the fluid reservoir which masks irregular astigmatism. They are made of high oxygen permeable materials, and there is less than 3% incidence of corneal edema with these lenses. There are currently 41 different designs for scleral lenses made by 17 manufacturers worldwide. The lenses are fit using trial fitting, impression techniques, computer-assisted lathe cutting such as the PROS lens from Boston, and wavefront guided optics. Here you can see the PROS lens in position, which masks surface irregularity and irregular astigmatism and provides a healthy reservoir of fluid for the eye. There are new, very interesting ways of fitting these lenses, including something like the iPrint Pro, in which you make an impression of the eye, a mold of the eye, which allows for extreme accuracy and gives us the opportunity to fit lenses in patients with filtering blebs and tubes in place. The OCT has become an invaluable tool in fitting these lenses, much more so than topography. Here you can see some examples of scleral lenses used in the dry eye. On the left, the pre-fitting cornea with diffuse punctate staining, and 4 hours after a scleral lens. Here you can see a persistent epithelial defect. There we go. And here you can see graft versus host disease after only 6 hours with tremendous improvement in the ocular surface. A series done looking at quality of life suggests very strongly that these lenses are applauded by patients. The limiting factors, of course, are always oxygen permeability, the conjunctival anatomy, the ease of fit, patient handling, and there are certainly complications, including corneal edema, neovascularization, papillary conjunctivitis, and so forth. So the disadvantages of scleral lenses are the cost, particularly in precision lathe cutting, training and fitting and modification. The pros include decrease in the rate of keratoplasty, the use of these lenses in post-PK and refractive surgery correction to avoid further surgery, and they are a viable alternative in the management of ocular surface disease. But of course, scleral lenses are not new. In 1888, Kalt cut off the bottoms of test tubes to use as contact lenses to suppress the cone in keratoconus. In the same year, Adolf Gaston Eugen Fick in Switzerland designed a contact lens. You can see Dr. Fick seated at the chair with his lab assistants and a patient, and really designed what looks very much like a modern day lens. Unfortunately, his experiments were not successful, and he abandoned the attempt. August Müller in Germany, for obvious reasons, he was a high myope, and he saw the advantage of contact lenses and was the first to design scleral lenses for refractive correction. You can see these early scleral lenses from the 1920s. They have large perforations, which are fenestrations for oxygen permeability. But then in 1960, when oxygen permeable materials became available, scleral lenses once again became a tool which has now been developed to be very useful for us. We'll just say a word about reshaping the cornea. No one in the United States should have the audacity to speak to a European audience about collagen cross-linking, since we are the third world in this area. Collagen cross-linking, as you know, is a hybrid medical surgical therapy first applied by Sperl and colleagues in 1998, applied for keratoconus in 2003, approved in Europe 10 years ago, and approved in the United States less than 6 months ago. So we have very little in the way of substantive knowledge to bring to you about collagen cross-linking. If, however, you look at the meta-analyses of the studies on collagen cross-linking, the results are actually conflicting. And cross-linking did not, of course, come from ophthalmology. Cross-linking was first used in bioprosthetic heart valves and by our colleagues in dentistry for the ultraviolet curing of materials for placement of prosthetics. The U.S. clinical trials include only 205 patients with a 12-month follow-up, and if you look at the results of both progressive keratoconus and corneal ectasia after refractive surgery, the results in the U.S. studies definitely show that collagen cross-linking prevents progression of keratoconus and post-refractive ectasia. It is not, of course, however, without complications, and virtually all of these complications are familiar to those of us who do collagen cross-linking. So in summary, this is an extremely promising modality for patients. We've heard several talks about collagen cross-linking in combination with other treatments yesterday. And there is a statistically significant decrease in corneal curvature, halting of the disease, but we need to learn a great deal more about this procedure. Collagen cross-linking, of course, the idea of flattening the cornea is not new. In the early 1800s, mid-1800s, and early 1900s, there were no options for keratoconus except corneal flattening. And a number of wonderful devices were described, such as this one, which is a pressure device which was applied to the closed lids to flatten the cornea. Here you can see it in use. And this one, which is even more intriguing, which is a device using air to either pull the cornea out or push the cornea in by modifying the air from your mouth. So the idea of flattening the cornea is not a new one. The mainstay of flattening the cornea in 1917, 100 years ago, was corneal cautery. And corneal cautery, although it scarred the central cornea, was often done in combination with a peripheral iridectomy for optical purposes. And that's really what was used until we developed penetrating keratoplasty in 1906. Restoring the corneal surface. Everyone in this room who does corneal surgery has probably used amniotic membrane, and there are multiple uses for this material, including pterygium surgery, limbal stem cell deficiency, conjunctival surface reconstruction, corneal ulcer perforation, post-refractive surgery, and Stevens-Johnson syndrome. Actually, I put Stevens-Johnson syndrome in red because I think that's its greatest application. You can use either cryopreserved or sutureless material or dehydrated material, and this is placed on the ocular surface for treatment of acute Stevens-Johnson syndrome. Here you can see a patient in which the amniotic membrane is sutured to the lids and the fornix and to the entire front surface. And these photos from Darren Gregory in Denver, who pioneered this procedure, you can see the same eye on your left and 6 weeks later on the right after treatment, early treatment with amniotic membrane. But amniotic membrane is also not new. Vladimir Filatov, one of the great pioneers of corneal surgery, actually developed a form of tissue therapy in which amniotic membrane or placenta was injected subconjunctivally, and then egg membrane was used as an overlay after keratoplasty. So here you can see a keratoplasty done in the late 40s with an amniotic membrane overlay and stay sutures in place. And this was so common that Ivor Lloyd in England developed a special trephine, which you would take to the operating room with a boiled egg, hard-boiled egg, carefully take off the shell, and then trephine a layer of amniotic membrane to place over the eye. Moreover, in the 1930s, amniotic membrane was already used for chemical injuries of the eye. Dry eye. We all deal with dry eye, whether we like it or not. And there are multiple approaches to dry eye, including lacrimal mimetics, lacrimal stimulants, immunomodulators, anti-inflammatory agents. Two innovations that are very useful are autologous serum and neurostimulation. Autologous serum, at its first report as an isolated therapy in 1975, was first used in Japan by Kazuo Tsubota in 1999, and has multiple uses. The varieties of serum can be used, including allogeneic serum, umbilical cord serum, platelet-rich plasma. And there are some issues with this therapy, but in general, it's very successful. In the United States, we do this by drawing blood. The blood is then sent to either a compounding pharmacy or the eye bank, and the eye bank separates the blood and the serum and then returns the patient's own serum to the patient in a 3-month supply. It works because of all the factors contained in the serum, including epidermal growth factor, TGF-beta, fibronectin, and so forth. There have been multiple studies of autologous serum, and the 6 randomized controlled trials show that it is effective in persistent epithelial defects and severe dry eye. People have used stored allogeneic serum as well. As we mentioned, umbilical cord serum, even human breast milk has been used. But serum was used as early as 1928 in the form of fibrolysine, and serum per se was not used until 1984. Another wonderful new promising device is the use of neurostimulation for the production of tears. Tear dysfunction occurs in 31 million people, at least in the United States. The current therapies we're all familiar with in our practices, but very little attention has been paid to the neural loop, which causes dry eye. This device, the Oculi, was first designed by a bioengineering student who was sent to an eye clinic at Stanford and was told to find a problem to solve. And he found the problem of dry eye. Over a period of a couple of years, they developed an intranasal stimulatory device, which is put in the nose. There have been 4 clinical studies with very promising results. They looked at Schirmer tests, the ocular surface disease index, conjunctival staining, and all of these studies showed a mean increase in Schirmer tests, decreased corneal staining, and 83% of the patients were satisfied. This is the Oculi device, which is scheduled to be released in the United States in July. And in this movie, you will see the Oculi device has just been placed in the eye, and in about 10 seconds, if you watch where the arrow is placed, you'll see a sudden increase in the lacrimal, right there, the lacrimal lake. Patients find this device very easy to use, and we anticipate that it will be a major tool for us in the United States. But of course, it's not new. Ernst Fuchs used electrical stimulation for dry eye in 1919. Galvanic gland stimulation was used in 1931, and other stimulatory modalities such as ammonia and pilocarpine. Going on to a final mention, and we talk about drug delivery, and drug delivery is not the strength of cornea people. Drug delivery is the strength of our glaucoma colleagues. We've used various modes to deliver drugs. numerous companies are working with our glaucoma colleagues to develop new forms of drug delivery. And the one I'd like to mention is the bimatoprost ocular insert. This is a ring which is impregnated with bimatoprost and is replaced every 6 months. It's easily placed in the eye. It's well tolerated by patients. And although this is used at the moment for glaucoma therapy, one can imagine that this could be a dramatic improvement for us if it were steroid impregnated or lubricant impregnated or used with any number of drugs which are employed in the management of ocular surface disease. The pros are that it's very safe. There's occasional discomfort with the device. It's easily removed if problems develop. And I have just 2 or 3 more minutes. And it's designed to last for 6 months. So for patients who require compliance therapy, this is a wonderful device. But of course, delivering drugs in unique ways is, again, not new. Dr. Wirtz in 1912 developed this set of iontophoresis devices which are used to drive drugs across the cornea. I'm going just, by way of introduction of my colleague who will speak next, say that there is something that is new, and that's cell-based therapy. Cell-based therapy may make all of these procedures, which we talked about this morning, antiquated by understanding the basic properties of cells to use instead of replacing layers of cornea. Shigeru will talk to you about this, so I won't mention it at all in view of the time. This has been tried before, but what makes it so new is that Fuchs, in his original article in 1910, it was very clear that Fuchs was not sure that the problem was epithelial. He called the disorder, which we now call Fuchs, dystrophia epithelialis corneae. And he said that I've called it dystrophia epithelialis, a name that can later be replaced when the nature of the disease is understood. Well, now 100 years later, we understand the disease. And our hope is that Dr. Kinoshita and his group will make it better. So what is new is really old, but we are making it better. And what will happen 100 years from now when we are all names in antique books? We will see that there is microbiome manipulation to manage ocular surface disease, that autologous tissue will be grown from the limbus with material characteristics identical to native cornea. There will be routine endothelial cultivation and chemical modulation already occurring. We'll hear about that in a few minutes. We'll use gene transfer to epithelial and fibroblast stem cells to reshape and re-engineer the cornea in patients with dystrophies that were discussed by our colleague this morning. Eye drops that will polymerize to form daily disposable contact lens correction, and gene therapy for dystrophies and other inherited.
Who are you? Why aren't you masked? Who are these people?
I don't know.
What the hell is that? What are you doing?
Tearing of the middle meningeal artery.
What's your degree in? Dentistry?
How do you explain slow impulse, low respiratory rate, and coma?
Fundoscopic examination.
Fundoscopic examination is unrevealing in these cases.
A simple evacuation of the expanding epidural hematoma will relieve the pressure.
My God, man. Drilling holes in his head's not the answer. The artery must be repaired. Now put away your butcher knives and let me save this patient before it's too late.
So you can see that in this episode from Star Trek, in which Chekhov has a subdural hematoma, the modern-day doctors in San Francisco are planning to do a trephination to evacuate the blood. But coming from 200 or 300 years later, the crew of Star Trek knows that there is a better way. So what will be in 2117, we don't know. I'd like to express once again my appreciation to my colleagues who helped me with materials, and particularly to my wonderful colleague at Holland, who has been my partner in education for many decades, and to my wonderful friend Enzo Sarnicola, for inviting me back. Thank you very much.
Mark, this is not gold, not silver, just a gift for you, but is full of affect for you.
Thank you.
From all the ophthalmology communities, because your contribute in our formation was amazing, great. Everybody studying your book.
Thank you very much. Thank you.